Welcome to today's Explainer. We're going to be turning the sometimes overly complex CPT guidelines into a really clear, actionable decoder ring for preventive medicine and behavior change. Now, if you deal with medical billing, you already know that preventive care is just fantastic medicine. But getting paid for it, well, that requires some highly specific, rules-based documentation. So let's dive into the manual together and uncover the exact codes you need to capture the absolute full value of these wellness visits. Here is our agenda for this explainer. First, defining preventive medicine, then age and patient status, followed by navigating Modifier 25 rules, and we'll wrap up with behavior change interventions. All right, let's jump straight into Section 1, defining preventative medicine, the foundation of wellness codes. So what does this all mean? Well, a comprehensive preventative medicine service really isn't just a quick pat on the back before sending a patient on their way. To actually bill these codes, the provider absolutely has to perform an age and gender-appropriate history and physical exam. It inherently includes counseling, anticipatory guidance, and ordering any necessary labs. Think of it like a holistic, top-to-bottom evaluation of a healthy patient, or, the routine checkup of a patient whose chronic conditions are perfectly stable right now. When we look at the exact CPT language for new patient preventative services, you'll notice how carefully the codes are categorized. The extent and the focus of the service rely heavily on exactly who is sitting on that exam table. The core clinical requirements, the history, the exam, the counseling, they actually scale dynamically based on the patient's age. But here is the crucial catch, and it's all about knowing what is not included in that primary code, because missing these details literally means leaving revenue on the table. Ancillary services are always reported separately. So if the provider gives a flu shot, does a vision screening, or orders a metabolic panel, you have to code those in addition to the wellness visit. They are absolutely not bundled into the base code. Moving right along to Section 2, Age and Patient Status, the coding matrix. The manual neatly splits these visits into two completely distinct tracks. First up, we've got new patients. That's codes 99381 through 99387. And as a quick refresher, a new patient is someone who hasn't been seen by the physician or someone of the exact same specialty in the practice within the past 3 years. This represents their initial comprehensive evaluation. Then, on the flip side, we have established patients, codes 99391 through 99397, which represents a periodic comprehensive re-evaluation. This structure creates a really brilliant, perfect decision-making matrix. Once you establish if the patient is new or established, your exact code is determined by 7 specific age thresholds. It starts with infants under 1 year old, scales step by step through childhood and adolescence, and tops out at adults 65 and older. Basically, you just trace the patient status column down to their age on the day of the encounter, and boom, you've found your base code. Now for Section 3, navigating Modifier 25 rules, the real-world complication. This brings us to a classic coding dilemma. Honestly, it's the kind of thing that keeps auditors awake at night. What happens when a patient is scheduled for their routine annual physical, but while they're sitting there, they complain of severe ear pain, or the doctor discovers a significant new issue? Do you bill a preventive visit, a sick visit, or maybe both? The entire rule hinges on severity. If the new problem is significant enough that it requires key components of a separate evaluation, you code both. You report the preventive code plus the appropriate sick visit code, like a 99213 for instance, and then you append modifier 25 to that sick code. But, and this is a big but, if it's an insignificant, trivial issue like a minor sniffle that requires no real extra workup, it just gets bundled right into the preventive visit. No extra code allowed. If you are going to use modifier 25, your documentation has to be bulletproof. It literally must prove the service was significant and separately identifiable on that exact same day. The provider's note needs a distinctly separate assessment, a separate history of present illness, or HPI, and separate medical decision-making, or MDM, for the sick visit. If the notes for the sick visit just kind of blend into the routine wellness notes, yeah, you're risking a very swift denial. All right, let's look at our final topic, Section 4, Behavior Change Interventions, Time-Based Counseling. Risk factor reduction and behavior change interventions operate on a completely different set of rules than your standard exams. These codes kick in when a provider sits down face-to-face with a patient to explicitly promote health and prevent injury. It's fascinating because these interventions target behaviors that are either considered illnesses themselves, like tobacco use, or they aim to stop a harmful behavior right in its tracks before it transforms into a chronic illness.
For individual counseling of asymptomatic patients, these codes are strictly time-based. They escalate in 15-minute increments, starting at 99401 for 15 minutes, all the way up to 99404 for a full 60 minutes. But here's a critical warning. If any other evaluation and management services are reported on the exact same day, you cannot double count this time to inflate the other code's level. This time is strictly walled off.
But what happens when the intervention targets highly specific, complex challenges? Well, we actually drop those general counseling codes entirely and shift over to a dedicated subset of time-based codes designed exclusively for validated behavior changes. Take tobacco cessation, for example. You'd use 99406 for an intermediate session of between 3 and 10 minutes, and 99407 for anything beyond 10 minutes. Substance abuse screening works in a very similar way, utilizing 99408 for 15 to 30 minutes and 99409 for longer sessions. Your code selection here is entirely at the mercy of the provider, literally watching the clock and documenting the precise number of minutes they spent face-to-face. And if your practice runs these interventions in a group setting instead of one-on-one, the code set shifts one last time. You'll utilize 99411 for a 30-minute group session and 99412 for a 60-minute session. This is an incredibly useful tool for capturing revenue from things like group dietary education or family injury prevention classes. Precision really is the ultimate tool in medical billing, isn't it? By mastering these exact age brackets, the strict time increments, and the perilous, often confusing rules of Modifier 25, you can transform your coding from a stressful guessing game into an exact science. So ask yourself today, is your practice's current documentation actually capturing the full value of the preventative care being provided? Or is that hard-earned revenue just slipping through the cracks? Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.